Hello and welcome everyone. Today's webinar is about borderline personality disorder and chronic pain. And so my name is Carlos Bello. I'm a physiotherapist and I'm the team leader of the Ambulatory Pain Management Service of Eastern Health. And I'd like to also introduce you to Alison Thomason, occupational therapist, Eddie Purnell, a physiotherapist, and then there's also going to be Sue Yenkin, who's going to join us. She's running late, and she's the senior health psychologist, and we're all part of the Ambulatory Pain Management Service of Eastern Health. So this webinar is part of a series of webinars, which you may or may not have come to before. We've previously had topics like complex regional pain syndrome with Anne Daly, and we have another sort of set of webinars later on this month about chronic pelvic pain, and that's being done by Mark Sherban. So I'd like to introduce Sathya. So he's actually an associate professor, and he is a psychiatrist and the executive clinical director of Spectrum, which is a specialist service for personality disorders in Victoria. He is the Vice President of the Australian Borderline Personality Disorder Foundation, and he is an adjunct clinical associate professor at the University of, Monash University. So Sathya is involved in clinical research and has published research papers, contributed to chapters, and has co-authored books on borderline personality disorder. He was a member of the NHMRC Clinical Practice Guidelines Development Committee in 2012. He has taught clinicians across Australia and was the head of psychiatry training program for Victoria with RANZ CP previously. So he's involved in treating complex personality disorder patients and provides second opinions and secondary consultations for complex clinical conditions associated with personality disorders. And if he hasn't done enough, he was the recipient of the 2020 Meritorious Award for the Victorian branch of RANZCP. Very, very decorated man. Thank you so much for being here. And I will hand over to you to speak to us. Thank you so much for coming.
Thank you, Carlos, for that very kind introduction. And thank you to everyone who is in the webinar today. Thanks for making the time. Okay, as Carlos said, what I hope to do is to spend about 35 minutes going through some slides. And then we should have plenty of time for questions and answers. I've done a similar presentation to the Faculty of Pain Medicine and also to a couple of pain programs. So I'm somewhat familiar with the relationship between chronic pain and borderline personality disorder in general. My experience is that about a third of our patients at Spectrum have chronic pain conditions. And I understand that at chronic pain clinics, again, 1/3 of your patients have a diagnosis of borderline personality disorder. So it's a very significant relationship. Okay, yeah. So a couple of words about Spectrum. Spectrum is a public mental service. We are auspiced by Eastern Health. We are a statewide program. What it means is that Eastern Health is only one of our catchment areas. So we travel across the state. We also travel across the country and do some clinical work, training we have done training and clinical work in all the states and territories in Australia. We are considered as a center of clinical excellence for personality disorders. And we work mainly with people with borderline personality disorder because they are the ones who are referred to us most commonly. Let's start with the definition of personality itself. The simplest and the most popular definition of personality is that it describes a person's characteristic style of thinking, feeling, and behaving. Okay, simple enough. Of course, this definition has been disputed because what happens if you don't have a characteristic style of thinking, feeling, and behaving? Does it mean to say that then you don't have a personality? Okay, that's a rhetorical question. I'll leave that to you to ponder about. If you're looking at personality disorders, it is defined as an enduring pattern of thinking, feeling, and behaving, which deviates markedly from the expectations of the individual's culture or background. And it is usually pervasive, inflexible, and stable over a period of time. And it should also cause significant distress either to the individual or to others and cause impairment. That's the definition of personality disorders. Now, personality disorders are extremely common. One of the studies in Australia shows that 6.5% of Australian adults have at least one personality disorder. If you're looking at psychiatry outpatients, half of them have a personality disorder in addition to other disorders such as depression, PTSD, etc. And the highest prevalence is seen in the criminal justice system. Now, we did a study from Spectrum. We looked at the coronial data for suicide in Victoria for a 5-year period. And our study has demonstrated that 10% of all suicides for all reasons is for a diagnosis of a personality disorder. So it's a significant mortality rate. Unfortunately, we still don't recognize personality disorders as a public health issue. So that leads to a very limited access to treatments, and also a generation of clinicians, including psychiatrists and mental clinicians, have not been trained in the science of personality disorders. So that's why you might come across that it is very difficult to refer patients to, if you recognize somebody to have a personality disorder, to get them to have appropriate and evidence-based treatments is very, very difficult. That's because very few people are available and trained to do so. And Carlos and I were having a bit of a chat. I think it was, I forget the name of the person, one of your staff was saying that they find personality disorders as one of the most challenging patients, which is true. Most psychologically challenging patients a physician can ever encounter, or a clinician can ever encounter, is for a group of personality disorder patients. Now, so because of that, even mental health professionals actively avoid working with people with personality disorders, especially borderline personality disorder. I'm not going to go through all the details of slides, but just as put it as a reference, this is sort of the cookbook we have, the classificatory system, the DSM, and in which we divide all personality disorders into 3 categories, and cluster B category involves a borderline personality disorder. We also have another classificatory system, which we call as the International Classificatory System for Personality Disorders, in which we have done away with different classifications. We just make one single diagnosis of a personality disorder, and then we might look at the dimensions of the personality disorder into mild, moderate, severe, and we look at predominant traits. Not important for you, but that's how the classification system is going. Now, the relationship between personality disorder and chronic pain is quite important. So it is said that personality disorders are more common in people with chronic pain when compared to the general population, and the prevalence studies range from 31 to 81%. 30% is the lowest figure quoted. And another study has shown that half of the patients with chronic pain had at least one personality disorder. And different kind of personality disorders are listed on this slide. Paranoid personality, borderline personality, and avoidant personality are all common. Now, most chronic pain patients have psychiatric disorders, at least an adjustment disorder. And PTSD, depression, somatoform disorders, substance use, personality disorders, all quite common. The literature would talk about personality change secondary to chronic pain. I would be interested to know what you think about that. And also pain prone personalities. So again, I'm interested in getting your feedback about these two conditions. Now let's focus our attention on borderline personality disorder. Why we should focus on borderline personality disorder? Because that's the most commonly diagnosed of all personality disorders, and it is the severest of all personality disorders. And it contributes to 95% of all personality disorder related suicides. Unfortunately, borderline personality disorder is a highly stigmatized and highly misunderstood disorder. Now, again, it's a very common disorder, 1 to 2% prevalence in the community. In a primary care setting, it is 6%. In psychiatry center systems, 20%. As we discussed, 30% of chronic pain patients have BPD. And if you look at the psychiatric presentations in emergency departments, it's about 10 to 15% for personality disorders. Now, when someone gets a diagnosis of borderline personality disorder, current figures show that the expectation is that they will have a 20-year reduction in lifespan. And that's a very important finding. And it is not the contribution of suicide to that number, that reduction in lifespan is not very high. So they suffer lots of medical problems for which they don't get the proper treatments, and the reduction in lifespan. Suicide rate for personality BPD is again 10%. Non-suicidal self-injury, which is cutting, burning and jumping and hurting themselves, is up to 85%. So this is John Gunderson, who is the one who coined the name borderline personality disorder. He makes a statement that BPD is to psychiatry what psychiatry is to medicine in terms of stigmatization. Also, there is a myth that BPD occurs only in women, which is not true. When you do the community prevalence studies, the gender distribution is quite equal. Unfortunately, a lot of men with borderline personality disorder end up in drug and alcohol settings, and worse, in criminal justice systems. Again, a BPD, it was initially thought that it usually only emerges during adolescent periods, which is now we know that it is not true. BPD can start at different points in time in life, but most commonly during adolescent period times. And BPD can present across different life stages. And I have seen a patient who is 96 years old with a severe borderline personality disorder. I've also seen someone with 12 years old with a borderline personality disorder. Our national guidelines permits us to start making a diagnosis from the age of 12. Now, the signs and symptoms of borderline personality disorder, which many of you may be familiar. The most important thing to remember about borderline personality disorder is identitylessness and instability, and non-suicidal self-injury, which is a signature symptom of someone with a borderline personality disorder. I've got a short video which goes on for about 5-6 minutes. I'll now request Carlos to help me out to play that video. It's a video compiled by a person who has experienced borderline personality disorder. That may be self-explanatory. Carlos, could we try playing that video? Yeah, thanks.
There are demons in my room. I hear voices on my room. If you want me, come and get me. understand, boy, that's the truth. Weaving night and day, trapped inside the big room with that small gold key. So many doors to choose from. Time is a school in which we learn. Time is a fire in which we burn. Essence of dream, cradle of grain. Standing all alone. Demons in my room. I hear voices in my room. If you want me, come and get me. Little black cloud, don't bother me. I heard that you were looking for the plane that crashed 10 years ago. I heard that you were hoping to grow wings and fly. So I heard you laughing when I said I found out what my life should be. She said, free me into another world. She said, free me into another dimension. There she goes, escaping the asylum. She said, free me into another world. She said, free me into another dimension. There she goes, escaping the asylum. Time, space, love and grace, yeah. Time, space, love and grace, yeah. Look past the ground, look all around, look up and down, yeah. I cried when I saw how fast you were dying. Your hungry expression made me think just a little bit more. Why did you let them do what you never wanted to choose? She said, free me into another world. She said, free me into another dimension. There she goes, escaping the asylum. She said, free me into another world. She said, free me into another dimension. There she goes, escaping the asylum. Time, space, love and grace, yeah. time stays.
Carlos, maybe we could leave it at that. So thank you for playing that video. Can you see the slides again, Carlos?
Yep.
Yeah, great. So the point I'm trying to make through that video is that see, these are all the signs and symptoms of someone who experiences bodily personality disorder, and it is going to inevitably play out even in the interactions with clinicians. So if they do get angry with clinicians, it's not that they are deliberately trying to get angry and behave in the way they behave. It's because of the disorder. So there's a bit of a problem because, of course, when someone gets angry, it's not something which we can tolerate and we can manage. It's hard for the clinicians to manage. But if that is a symptom of the disorder itself, then can we blame the patients? Okay, now this is DSM criteria for borderline personality disorder. There are 9 criteria. I'm not going to go through them. They're all captured in that video. You need any 5 to make a diagnosis of borderline personality disorder. Now, borderline personality disorder co-occurs with other psychiatric disorders and other medical disorders. And in fact, it is called as the king of comorbid kingdom. I just want to draw your attention to the 3 items, which is the chronic pain, which we discussed. We also find that polycystic ovarian syndrome is very common in borderline personality disorder. In our clinic, about a quarter of my patients have polycystic ovarian syndrome. It's a very curious co-occurrence. We are investigating more about it. Again, obesity is quite an important co-occurring problem. What happens for BPD in the context of chronic pain? Now, so we spoke about the statistical positive association between chronic pain and BPD, even when compared to other psychiatric disorders. And you people would know more about these things, that the pain processing in borderline personality disorder is clearly abnormal. The pain threshold is elevated with BPD. So you know that people with borderline personality disorder use self-injury as an emotion regulation strategy. So when they have a chronic pain condition, what we've a diagnosed chronic pain condition as well as borderline personality disorder, what we find is that their pain threshold for acute pain is increased. So when they are indulging in cutting behaviors, they feel very little pain. However, when they have a chronic physical pain, there the threshold is much lower. So I think that's called the pain paradox, if I'm right. So what seems to happen is the altered processing of the nociceptive stimuli in the prefrontal and limbic areas, and the pain leads to neural deactivation of the amygdala. And amygdala is hyperactive in borderline personality disorder. When do you suspect borderline personality disorder in your clinical settings? Perhaps if you see patients where there are difficult interpersonal interactions, demanding patients, non-compliant patients, disruptive, if patients are taking a lot of time with your consultations, patients who are extremely emotional or given to frequent anger outbursts, rejection sensitivity, etc., etc. This is sort of the list of contexts in which you might want to suspect a possibility of borderline personality disorder. Now, rejection sensitivity is very common, and it is a feature of personality disorder, borderline personality disorder. It might happen in the context of refusal of medications. So if you refuse to prescribe certain medications which they demand, that can be perceived by patients as being you rejecting them. Again, discharge from hospitals, discharge from your treatment, or if you fail to follow them up, that might be perceived by patients as you abandoning them completely. Now, BPD presentations in the context of chronic pain, BPD patients presenting with chronic physical pain after a minor trauma or trauma that does not fully explain chronic pain, or patients seeking validation, or the physical pain when it is more acceptable, because physical pain is seen as more acceptable than emotional pain. So that seems to be the presenting complaint. Some of the other conditions where situations where to suspect BPD is repeated self-harm behaviors, repeated crisis, emotional instability, excessive emotionality, and repeatedly expressing suicidal feelings or making suicidal attempts. These are some of the ways to screen and diagnose borderline personality disorder. Of course, you need a clinical diagnosis, but using DSM-5 criteria, there are a couple of questionnaires, the BPQ, the borderline personality disorder questionnaire, or something called ZAN-BPD, which is a 10-item questionnaire, which we use most commonly in our clinical setting. It takes about a couple of minutes for patients to fill it up. So that's a good screening tool. There are a lot of commonalities between chronic pain management and personality disorder management, perhaps. I would be interested to hear your feedback about this. So trauma appears to be very common, both in physical and psychological pain, and both are chronic conditions, both have multiple comorbidities. Substance use disorders are very common. There's significant care burden with both these disorders, and both these disorders are quite challenging to treat and usually involves long-term treatment. And it also results in significant stress and burnout in staff and clinicians working in chronic pain clinics as well as in personality disorder clinics. At the same time, it can be extremely rewarding to work with these patient groups. Look, I have been working with personality disorder patients for the last 20 years now, and my job satisfaction has never been better. So I would not trade this work for anything else, because people with personality disorders take a long time to recover, but once they recover, they stay recovered. Okay, this is a case example of someone whom I've treated. This is a 30-year-old woman with a history of borderline personality disorder since the age of 12. And she has been in treatment for a long time with psychological treatment. She developed chronic abdominal pain of 9 months duration following a sexual assault as an adult. And she consulted a pain physician, and she was diagnosed with irritable bowel syndrome and visceral hyperplasia. All investigations were, of course, normal. She was prescribed Endep and Lyrica, later on Topamax and Carapres. She was seen by an OBG specialist, twice posted for explorative lab surgery and cancelled. Went off medications as it did not help her. However, she recovered with psychotherapy over a period of time. Now she's 35 years old and doing well, and a remission from both chronic pain and borderline personality disorder. So we're left with this. This is not an uncommon scenario for us. So we're left with the question of how much was chronic pain, how much of it was borderline personality disorder, whether both the conditions were helped with psychotherapy. Lots of questions there. What causes borderline personality disorder? See, we still don't have a final answer, but what we know is that there is significant genetic predisposition. So the heritability effect is 0.69, which means that 60% chances of heritability. And that coupled with childhood experiences, which is usually childhood trauma or attachment problems, seems to result in borderline personality disorder. The biological abnormalities that we know of in borderline personality disorder are an hyperactive amygdala, and coupled with that, a poor cortical control over amygdala. So as you know, the limbic system, the amygdala, that's where the emotions are generated and emotions are produced. And it is the prefrontal cortex which regulates the emotions. Now, if the connections between the prefrontal cortex and the amygdala are disturbed, then you can expect a situation where there is going to be poor control over emotion. That's what seems to happen with borderline personality disorder. We also know that people with borderline personality disorder have difficulty in forming trust and cooperate. And incidentally, there is a problem in the anterior insula in the brain, which leads to incapacity to cooperate and form trust. So prefrontal cortex has less control over the amygdala, as we discussed. Now, if you think in borderline personality disorder, people experience emotions very, very intensely. For the same trigger, for the same stimulus, the intensity of emotions experienced by people with borderline personality disorder is much, much higher. And on top of that, and as I've been saying, the control of the cortex over the amygdala is limited. So if you consider this analogy, it is as though people with borderline personality disorder are driving a car with very, very sensitive accelerators, which is the emotion system, the amygdala, and very poor brakes, which is the prefrontal cortex. So no wonder these patients go through red lights and they drive erratically. And unfortunately, that is not visible. When someone looks at this person driving this car, it is as though everything is fine. So for their poor driving, erratic driving, they're often judged very negatively. That seems to happen very clearly in borderline personality disorder. Now, how do we manage the condition? The demand for clinicians is to be a driving instructor sitting in that car where there are poor brakes and very, very sensitive accelerators, and teach the person how to navigate and how to drive that car. And we need to be an empathic instructor at that. And so that's why the clinicians find it so hard to work with people with borderline personality disorder. But what we know in research and science is that if clinicians can teach the patients how to manage their emotions and regulate their emotions and navigate their life with skills to manage their feelings, emotions, and behaviors, over a period of time, these patients get well. And despite having poor brakes and despite having poor cortical controls, they are able to manage their emotions. So, having borderline personality disorder is not the person's own fault. It is a disorder of the brain and the mind. So, it is very clearly established that borderline personality disorder is a severe mental illness. It is not just a condition, it is not just a disorder, it is a clear mental illness. Having the same biological predispositions and the environmental influences as it is common to all psychiatric disorders. No doubt, these patients can be difficult to treat, difficult to work with, but it is the illness that produces the behavior, not the person. Fortunately, we don't have any medications that are patented or indicated for borderline personality disorder. So that's why it becomes more difficult. And psychotherapy is the treatment of choice. And we have worked out the treatment principles, which I'm not going to go through now. I'll give away the slides. Most of them are very clear, simple, common sense based treatment principles to make a diagnosis, to delineate suicidal behaviors, self-harm behaviors, to have a joint crisis management plan, which seems to be very, very important, and to educate the patient and family about the personality disorder and setting up a clear contract and avoiding hospitalization as much as possible for borderline personality disorder treatment, and not to prescribe excessive amounts of medications. And the other most important principle is to validate. Validation is accepting their condition, their situation as it is, and allowing them to acquire the skills over a period of time. I might show you a brief video of a couple of minutes to drive home that point.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me. And I can just feel it, like literally feel it in my head. And it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there.
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing.
You always do this. You always try to fix things when what I really need is for you to just listen.
See, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just
Don't.
Try to see things my way. Do I have to keep?
That's a bit of an illustration of what really happens. See, often we know what the problems are, but the demand for us is to not to jump into fixing the problem, but to give time for the patients to be heard and listened to, and then work through the problems. See, again, I'll spend only a couple of more minutes summarizing the rest of the slides. I'm not going to go through all of them. There's a list of all the psychological treatments. They're all absolutely evidence-based and they work. And with any of these treatments, most of our patients go into remission within 1 to 2 years' time. Now, all of those treatments are equally effective, and there are more commonalities than differences. We have distilled all the common factors in them, and we have devised psychological treatments. There's a summary of outcome studies. The prognosis is actually quite good for borderline personality disorder. If only we could give them psychological treatments. 10% of them improve in 6 months, and up to 85% of them go into remission in 10 years' time. 60% of them recover in 16 years' time. This is any treatment for that matter. And relapse rates are very small. Now, if you provide good evidence-based psychological treatments, within 1 to 2 years, about 2/3 of the patients go into remission and they become asymptomatic. There are a few medicines which have been tried, but again, none of these medicines are patented or indicated. They might take the edge off some of the symptoms. You might recognize topiramate and lamotrigine because I understand you use those medicines for chronic pain. So when patients have chronic pain and borderline personality disorder, we tend to, my most favorite go-to medicine is lamotrigine, because lamotrigine can help reduce the emotional instability, impulsivity, and anger, in addition to being helpful for chronic pain. Omega-3 fatty acids, again, lots of evidence in borderline personality disorder, so we use that. So finally, the take-home message is that as long as you don't judge, as long as you try to validate the valid, and trying to really look into something to validate in the patient, and as long as you can tolerate emotions, your emotions and their emotions, and teach them skills to improve their quality of life, you can contribute to the recovery journey of people with borderline personality disorder. So my invitation to you is to give it a go. So I'll stop here and happy to take questions and comments.
Beautiful. Thank you, Sathya, for that presentation. I think there's been just a few comments. I guess probably for me, I'd like to maybe start by asking a question myself, and then maybe Eddie, Ali, or Sue might be able to ask questions, or others may want to pipe up and write in the chat. But my question is that, so I guess, with a pain service, we have patients that tend to, there's a lot of FTA, and I think that it has something to do with, borderline personality disorder and, those kinds of concerns. So I'm just wondering about how you would go about, improving patient engagement with our service who have these kinds of, who have the borderline personality disorder.
Thanks, Carlos. So you're talking about patient engagement for treatment of chronic pain, correct?
Yeah.
Do you have a sense of what are the factors which may be contributing to less of an engagement?
Sorry, could you say that again?
Do you have a sense of what are the factors which may be contributing to poor engagement?
I guess, with people with chronic pain, I think there's a few. I guess the chronic pain service itself, people maybe aren't really up for the paradigm of chronic pain management versus like looking for a cure. I guess there's other things like the psychosocial, there's the like the social economics of FTAing. People can't get out of work, or they have, poor funds to be able to support transport, those sorts of things. I think Eddie has something to add to that as well.
Yeah, and I think also poor time management and appointment management, just with lots of medical professionals being involved, is also key. They often, they'll fail to attend, we'll follow up with a phone call. Oh, I didn't know about it. They require a lot of hand holding. They require that text message that morning saying, I can't find the link, I can't find the phone. Like it's a lot of work, and they make it quite a dramatic, being non-judgmental, but they make it quite a dramatic process.
And I'm Sue, I'm one of the psychologists. Hi, thank you for your talk. I was just going to say that there's always a lot of drama, social drama happening in their personal lives. So, it's sort of drama ridden and drama filled, which then affects capacity to, follow through with appointments and be on task with time management and prioritizing and things like that.
See, in terms of engagement, there is a 30% dropout rate for this population is acceptable. Those are the global standards. 25 to 30% of patients with borderline personality disorder drop out or have erratic engagement or miss appointments. That's acceptable. However, what we have found is that through telehealth, our engagement is almost 100% now. So people don't cancel appointments. So the key strategy I would suggest is, people with borderline personality disorder are not looking for a fix, although they need a fix. And they're asking for a fix, but again, not looking for a fix. So they're looking for interpersonal contact. So if the therapeutic relationship is strong, then the dropout rates are less and the cancellations are less. So that's again quite well established in our literature. So it goes back to the last slide I was put, being non-judgmental, accepting them as they are. There is a principle in dialectical behavior therapy about acceptance and change. Now, we all would know if somebody told us that they want us to change some of our behaviors or some of the ways we do, the immediate feeling that we get is that some of you are not good enough. There's a little bit of judgment that is perceived. When someone asks the other person to change, the very fact that we are asking them to change means that what is current is not good enough, correct? Therefore, we need to balance change with acceptance all the time. So change with validation. So validation and demand for change it's like a very delicate ballet dance. So we just need to keep, so there are times when we can push changes, teaching them skills, and there'll be times when you have to pull back and go for validation, especially when they're in a crisis, when they're angry, upset, when there's a lot of drama happening in their lives as super. At that time, driving changes is going to be impossible. So those sessions may have to be purely validation. And even if like that video you saw with the nail, it's very clear. So she has to remove the nail, right? That's the solution. But she's not ready to remove the nail. So at that time, if you want to pull out the nail, it's not going to work. Right? First, you need to validate, and then you can start working about the change. So in that video, suppose this person had validated her enough, then gently started talking about how the nail needs to come off. That would have probably worked. So you may have to do, in our work, I see patients usually for 1 to 1.5 years. The first 6 months is just validation validation, validation, and validation, and validation. I'm looking for opportunities to validate. Even when they attempt suicide, attempt self-harm. Of course, you don't want to encourage that behavior. At the same time, you can understand why in the way they perceive, that would be the end point. But of course, you won't immediately work through that and say, give hope. So you want to always find something to validate. That's crucial. If you don't validate, so you lose the patient.
Yeah.
Great.
I'd have to agree with you that what I call empathy and crediting is a very important part of the therapeutic alliance, and for clients, getting them on side and creating an environment where there's a relationship and possibilities for change.
Can I ask a question?
Yes, go ahead.
Thanks, Sue. Sathya, my question was about like managing these clients and managing our own emotional health and mental health while seeing a lot of clients with personality disorders. I find there's a lot of like transference and emotional contagion, and I feel myself getting anxious and things like that. Have you got any tips, given that you've worked with these clients for many years and you still want to do it?
A few strategies that are very important. Number one, you need to have someone to debrief with. In our system at Spectrum, our clinicians would receive 5 levels of supervision and support. They're extremely well supported. And that is crucial. Our clinicians talk and talk and talk and talk about the patients. So what it does is that we need to be able to debrief and manage and metabolize our emotions. So when you work with people with borderline personality disorder, you are going to experience significant and challenging emotion. That's a given. That doesn't mean that you're a weak clinician, you're a clinician of less competence. No. So if you're actually experiencing significant emotions, that means you're actually doing the work with these patients. So that's a given. But then we need to have processes and systems to metabolize those emotions appropriately, so that we don't carry those emotions back to our personal lives. Or worse still, that those emotions get spilled over in our interactions with patients. So when we don't adequately metabolize emotions, we can get angry with patients. We can be rejecting of patients. We can demonize patients. So we need to have systems where there is an organized supervision group, for example. Even if nothing can be done, at least having a chat with your colleague or a cup of coffee or over a Zoom in these conditions. So anything to debrief is very, very important. So having said that, look, I do a very small private practice. On the day I do my private practice, I see about 10 patients for psychotherapy back to back. That day evening, my empathy bucket is completely empty. That evening, I just can only go and chill out in front of the television and go to sleep. So you need to keep doing things to replenish your emotional. See, for me, the biggest feedback is that when I talk to my colleague psychiatry, they work with people with schizophrenia, bipolar disorders, where patients keep relapsing. And cure is not there. So with PPD patients, my experience is that it takes a couple of years. Then when they're well, they remain well. And usually I get Christmas cards, cards saying that they're getting married, or they got a job, or they had a child, which is a huge positive feedback. So generally we ask people not to take on too many patients, especially in severe specialist center. We got all the levels of supervision. If you don't have that, try not to take on too many patients. But if you have more than 3 to 4 patients on your list, if you're a full-time worker, it's too much.
About 50.
So if you have the resources, we can help you to set up a kind of a peer supervision group and the principles of that.
Great. Sathya, I'll definitely try to bug yourself or Josephine about learning more about like a peer supervision group, actually. There's a question here by David. Would you advocate working with BPD before chronic pain?
Look, you can, but it shouldn't stop you from working with both the conditions together. It's not out of my experience. I think I was talking to Carlos saying that my wife is a pain physician and she's also a psychiatrist. So from what I hear from her is that she works with people with personality disorders and chronic pain simultaneously. So if I had to reflect on that experience, one can work with both the conditions. As one of the, I didn't have much time to go through the slides. In one of the slides, I've listed how the management of chronic pain and management of borderline personality, there's so many similarities. The principles just overlap. And acceptance and commitment therapy is one of the treatments that we use for personality disorders. I understand you also use it for chronic pain. So there are a lot of overlapping conditions. And I also understand that when you're looking at a psychological pain, which is characteristic of borderline personality disorder, and physical pain, the cortex, both of them intersect and interact. So it makes sense to work with both the conditions together.
I think
time for another question.
Yeah. If I can just quickly say, I think it's one of the key things is to be, aware that that a comorbidity or like a secondary diagnosis on top of chronic pain, that it may be a psychiatric that exists, and then also to manage that as well. There is some research that says that if you do work on BPD for someone who's got BPD and chronic pain, that their chronic pain is more likely to resolve. Sorry, Ali, go for it.
Oh, that's okay. It was just a quick question because, one of the messages, I'm an occupational therapist, Sathya, from the pain clinic, and a lot of our therapies have to be brief therapies because of the nature of our service. And unless we remodel our entire clinic, we have to stay in that sort of brief intervention model. And particularly for our medical team, they're often doing things in short bites, and maybe it's, like you were giving an example of refusing medications or trying to divert a patient away from a medication that they're wanting, that medically is not going to necessarily help them in an ongoing fashion, or might have some dangers associated with it. Are there any particular techniques or language or styles there where you can marry that validation and change that you speak of in an effective way, in a brief intervention capacity? Because you've been talking about lots of long-term therapies, but I'm wondering if we can.
Look, we also have multiple brief intervention packages. We have a 10-session model, and we have a 20-session model, and we even we have adopted acceptance and commitment therapy for a 3-session Wise Moments program. So we can, in fact, if one of the things which potentially we could do, given that we are in the same service, is whether we can together come up with a model, a 10-session or whatever model, where which addresses both chronic pain and BPD from a psychotherapeutic point of view. If you look at our website, we have actually published the 10 and 20-session model. It's for free download.
Okay.
And it's under publications if you go look at it.
Sure, we'll definitely have a look. I guess I was wondering about, the doctors that are in the moment trying to help someone with BPD make some changes from a medical or even just an action point of view, which therapies might be useful for them for their pain, whether there's sort of particular techniques or language that is useful to help with that change, behavioural change. Yep.
So again, I go back to validation. Really. Yep. Validation. And it's also, we need to see, as health professionals, what are we all trained in? We're all trained to bring about changes in patients. Somebody has pain, we want to remove the pain. If somebody has fever, we want to remove the fever. If somebody is coughing, we want to resolve the cough. So our entire science, health science, is around bringing about change. But with borderline personality disorder, that is not going to work. We need to marry that change technology with acceptance technology. That's where the problem is, because we're all oriented towards change technology. So I'll give an example, a couple of examples. So earlier in my career, when I started working with people with personality disorders, there's one patient I remember. I worked for 6 months, and she stopped self-harming. She stopped cutting, and she stopped going to hospitals. I was feeling very thrilled. I thought, no, I did a good job. And in the next session, I was cheering up, saying that, no, you did brilliantly well, and you stopped self-harming. That's very good, etc., etc. But I could see that she was not really feeling excited about it. She was not feeling too good about it. So in the next few sessions, she started self-harming very severely. So later on, at one of the sessions, I went back and asked her, what really happened? So she told me that I never expected this. She told me, look, you felt so excited and you were so happy that I stopped self-harming. I thought that means you're going to stop seeing me. Right? So it was rejection for her. She felt abandoned. She was perceiving potential abandonment. The second thing she said is that, I know you felt very good about it, but I was not feeling it. I didn't feel very nice about giving up self-harm. So we need to be very attuned to what patients are feeling. So we need to really modulate our emotions. So this is exactly what I meant by being aware of our emotional reactions and modulating what we do. So in that situation, what I should do now what I would do is that I would just let it pass. I would not make a big issue at all about it. I would ask her, how are you feeling not having self-harmed? What's your experience? And validate. If she says that, no, that really feels much horrible than before, at least because of self-harm, I could manage myself, I regulate my emotions. Now it is, no, I don't even have the regulation strategy, and it's really very, very hard for me. I would validate that. You know what I mean? So half of the work is actually keeping my mouth shut and being aware of my own impulses to react and my own urges to say something, and filtering all of that and being very careful. That's really half of the work. And looking for opportunities to validate, and looking for opportunities to really at the end of the day, we want our patients to to recover, which means having meaningful relationships and being productive in work or career. So that's another thing which we always look at. I guess that's the same thing for you too with chronic pain. We are always looking at how patients can get into some sort of a job, and even if it is half a day a week, just going and working in RSPC with animals, something to do. We are always pushing our patients to do something, and always looking at a meaningful relationship. If they are dysfunctional relationships, we want to help them to get rid of that. And if they are relationships where they are actually contributing to the dysfunction, we want to help them out so that they can have meaningful contacts.
Yeah, Sathya, we work very much with values and asking them to identify what's meaningful and important to them. And we do look at different life domains like relationships, like work, like health, like, leisure, all those sorts of things. It's a very important part of our program.
Oh, great. So it looks like there are a lot of commonalities between the work that both of us do.
I think there needs to be, as you said, with the statistics, we seem to have a very high percentage of borderline personality disorder, whether they've been diagnosed or not. We notice there's massive emotional reactivity and drama in their lives.
Sathya, we recently got CL psychiatry back after a bit of a break, just because of COVID and the redirection or redeployment of people, and we're really happy about that because we just need that level of support. I think that as you said, 1/3 of our patients do have some sort of borderline personality disorder, and then there's the other mental health domains as well. So I think this has been really fantastic. Thank you so much for making the time, and hopefully we can be in touch with yourself and then also with your wife, who we, might have another commonality about. She might want to come and, work here with us. But yeah, I think that one of the things that, is there is that, you're a very well decorated man, and congratulations on your most recent award. But I think that what I got from today was also, a really huge depth of, clinical experience that informs, what you're doing in research and leading, clinical, guideline development. So thank you so much for spending time with us, and we will be in touch, requesting some additional support, if that's okay with you.
Absolutely. So thank you for the time and the opportunity. Thank you, Carlos, Sue, and Alison, and others. Thank you.
All right.
Thank you very much.
Okay. See ya.
Thank you. Bye-bye.